We recognize there's a problem with our loved one. We see a change in their personality. We see a change in their memory. We see that they get confused over things they didn't get confused over previously. It's time to go and get a good assessment. We'll probably start with the primary care physician because we need to know, is this a delirium? Is it a depression? Is it a dementia? You know what? It may be all three too. So we need to make sure that we get a very, very good diagnosis. And that's what we're going to look at next.
We'd like to talk to you about the proper assessment and how important that is. When you're looking at a diagnosis of dementia, saying that someone has dementia really doesn't tell us a lot, because there's over 60 causes of dementia that we know of today. What we really need to know, is it Alzheimer's? Is it Lewy body? Is it dementia due to a stroke? The diagnosis is most important.
Getting a proper diagnosis is extremely important because by definition, dementia is irreversible. And once you have a diagnosis of a disease that causes dementia, you then have to go on a track of minimizing the results of the dementia and taking the appropriate medication. But unfortunately, if you are in the hospital sometimes, you can experience delirium, which often looks like dementia. And you'll find in many instances that the hospital may recommend that the loved one goes to a nursing home or assisted living facility because they appear to have dementia. You still want to get it looked at, I think, by a neurologist or by someone who understands dementia. The other thing is depression. Depression is, particularly severe depression that's gone undetected for a long period of time, looks very much like dementia. And depression can be segregated from dementia by some very simple tests. So getting an accurate diagnosis is critical to determining a long-term strategy.
I mean, there's some very primitive things that can be done to diagnose it. One is giving the doctor an accurate picture of the mental state. And that's where the log in the journal comes in, where you're documenting these idiosyncrasies like, no longer wanting to deal with the paperwork, the agitation, the frustration. That's the kind of information that the doctor needs to start to formulate a decision. Then there's something fairly simple called the mini mental state evaluation test, which is virtually a 10-minute, 15-minute kind of thing that gives you a little bit of a quantitative insight into the existence of Alzheimer's. So it's a combination of things, MRIs. I mean, the only thing that really is definitive, unfortunately, is an autopsy and a lobotomy. Energize, the doctor is going to get no value out of that visit because they're not going to see the true characteristic of what's going on. I used to send the doctor, and I had both my aunt and uncle in an Alzheimer's condition simultaneously a few years ago. I put together like a 2-page, handwritten or in some case typed, of this is what's happened since the last visit, and it may have only been 2 months ago. And it was a detailed, almost by day chronology of the idiosyncrasies of behavior, the wandering phase, or the agitation phase, or the sundowning. These are all terms you'll see in the various Alzheimer's booklets.